Okay, well, the time is 1 p.m., so I'm going to end the Good afternoon. I'm Megan Huth, Research Assistant at Benjamin Rose. Thank you for joining us for the 19th Annual Katz Policy Lecture on Advancing Dementia Caregiving. Today's webinar will be recorded. Throughout the session, feel free to submit questions using the Q&A or chat feature at the bottom of your screen. Our team is monitoring the chat to relay your questions to our presenters and assist with any technical inquiries. You can access captions by selecting Live Transcript, the button with 2 C's at the bottom of your screen. The recording of today's lecture and accompanying PowerPoints will be available after the presentation and can be found in the resource library on our website, www.benrose.org, alongside all our other webinar recordings, videos, and articles. If you'd like to engage with us on X or Twitter during the lecture, please use our handle at benrose1908 and the event hashtag #KatzLecture. Now I'll hand it over to our President and CEO, Reuben Bell, who will introduce today's lecture and our keynote speaker. Reuben?
Thanks, Megan. Good afternoon. My name is Reuben Bell, and I'm the President and CEO here at Benjamin Rose. And I want to thank you for joining us for the 19th Annual Katz Policy Lecture. Our topic is on advancing dementia care. Our focus will be around groundbreaking research and innovations in dementia care with this year's lecture. The Katz Policy Lecture was established in 2007 and pays tribute to the esteemed legacy of Dr. Sidney Katz, who was a distinguished scholar at Benjamin Rose. And this annual event serves as a platform for advocates to delve into policy solutions for critical aging issues. Dr. Katz was a scholar, a physician, a scientist, an educator, a mentor, an author, a public servant, and a trailblazer in promoting active aging and advancing the field of geriatrics care, including the development of the concept of activities of daily living that many of us still use in conversations about the care and independence of older adults. The Katz family has remained steadfast supporters of Benjamin Rose, advocating for our mission over the years. It is now my great honor to introduce this year's Katz Policy Lecturer, Dr. David Reuben. Dr. Reuben is the Archstone Professor at the David Geffen School of Medicine at the University of California at Los Angeles and is director of the UCLA Alzheimer's and Dementia Care Program and the UCLA Medicare and Medicaid Innovation Guiding and Improved Dementia Experience, or GUIDE program. Dr. Reuben is past president of the American Geriatric Society, and he served for 8 years on the American Board of Internal Medicine's Board of Directors, including as its chair. Dr. Reuben serves as the chief of the UCLA Division of Geriatrics for 31 years, and he's a member of the National Advisory Council on Aging of the National Institute on Aging. In 2012, Dr. Reuben received one of the first CMMI Innovation Challenge Awards to develop a model program to provide comprehensive, coordinated care for patients with dementias. And in 2018, he was awarded a multi-site PCORI and NIA-funded pragmatic trial known as DCARE to compare the effectiveness of a health system-based and community-based dementia care program compared to usual care for those with dementia. Dr. Reuben is the principal investigator of the grant from the John A. Hartford Foundation to disseminate the UCLA Alzheimer's and Dementia Care Program. He has served as the joint principal investigator for the PCORI and NIA-sponsored STRIDE study, which is the largest fall prevention clinical trial to date, and led in the development and implementation of that intervention. Dr. Reuben continues to provide primary care for frail older adults, including making house calls. And in his spare time, he has written 10 plays and lyrics for 20 songs with composer Sidney Sharp. A compilation of those first 10 have been recorded. Dr. Reuben, it's a great honor to have you here today, and I hand the program over to you. Welcome, sir.
Thank you, Reuben. Let's see if I can get my screen share here. Are you able to see the screen, full screen? Good.
Yes, we can.
All right, good. All right. It was 1986. I was at Brown University as a junior faculty member, and my fiance had just graduated her residency program and was in the Harvard Advanced Fellowship training, learning research. And she would come home. She was just so excited, all the things that she was learning. So I got itchy and a little jealous and went to my chairman and said, I think I want to specialize. I want to get more training. And he looked at me and said, have you ever thought about geriatrics? I think that's going to be the way of the future. I said, well, I've always enjoyed caring for older people. Yeah, I think that might be interesting. He got on the phone and called Sid Katz, who happened to be a faculty member at the time. And I met with Sid, and then Sid called John Beck or David Solomon, one of the two who was out here in Los Angeles. And my life has changed forever. So thank you, Sid Katz. I did remain in contact with him throughout the rest of his life. He was a tremendous influence on me and obviously changed my life. All right, let's see. Okay, what are we going to talk about? Why is dementia important? What is dementia? What causes it? And what's the prognosis? Then we'll talk about management of dementia, management of the disease. We'll touch briefly on the medications, manage the patient and the caregiver, manage complications. And then I'll speak briefly about the Dementia-Care Study. And finally, we'll end up with guide. What do these people have in common? Well, depending upon your age, you may not even recognize these people, but we'll go around. This is Rita Hayworth. She was a famous actress. If you haven't seen it, watch Gilda. Charlton Heston, famous actor. Ronald Reagan, we know who he was. He was the president of the United States. Gene Wilder. If you haven't ever seen The Producers, you should see that. And Willy Wonka. And Glenn Campbell. And they all had Alzheimer's disease. Yeah. Just so nobody is spared. Alzheimer's and other dementias are the worst fear of aging, and with good reason. These are data for Alzheimer's disease, but it is a disease of aging. So age 65 to 69, about 3.5% of people have Alzheimer's disease. But by the time people reach 90, it's about 35%, which means that if you're sitting next to your brother on one side and your sister on the other side, the odds are that if you live to the age of 90, all of you, that one of you will have dementia. That's huge. There are higher prevalence in African Americans and those with lower education. And currently, it's estimated that 7.2 million Americans have Alzheimer's disease. Now, looking forward, this is reading the tea leaves. With the aging of the population, 74 million of us baby boomers, will begin to reach the age of 90 in 2036. That's 11 years from now, but that's that 1 in 3 age group. Okay, so there's a lot coming. Second, new diagnostic methods, we'll talk about those in a little bit, will increase the prevalence through earlier and more precise detection. So all the estimates of how many people with dementia are probably an undercount. These will largely be blood-based biomarkers and better scanning. And finally, dementia care is different than other chronic diseases. Not only does it affect the person who with the disease, but the caregivers in particular, and the manifestations, particularly behavioral manifestations, are different than any other chronic disease. Oh, so that would not really justify things, although a very common disease. But the problem is that these people with dementia are getting poor quality of care. And this is a series of studies that were done that quality indicators, these are if and then statement. If somebody has dementia, their family should receive caregiving information. And you see here that it's not been good. Cognitive evaluation of positive screen, only 25%. Checking medications for possible contributors, less than 10%. Caregiver support, the very essence of dementia care, fewer than 1/3. Monitoring for behavioral and psychological systems, fewer than half. And moreover, there are poor linkages to community-based resources. We'll get into that in a bit. But it's interesting. I was seeing patients yesterday afternoon, and one of my patients who has moderate dementia, his wife spent the greater part of the visit telling me about how the ophthalmologist and how the gastroenterologist and how the surgeons didn't know how to treat her husband. Consequences. So this is a big ticket item, $384 billion in healthcare costs for persons with dementia. These are the most recent data. Higher all kinds of costs. And then the caregivers. Almost 12 million, providing almost 20 billion hours worth of care with an estimate of over $400 billion. And if you take a look at the cost per person in all the categories, Medicare, Medicaid, and out-of-pocket, much higher. And in fact, you think about a person with dementia from a health policy perspective costing about 3 times as much as somebody who is older who does not have dementia. So what is dementia? So the definition we're currently operating under, and that's a caveat because things are changing here, is the 2011 NIA Alzheimer's Association definition. And it is a chronic acquired to differentiate it from a developmental disorder, not explained by delirium, because delirium can cause the same kind of symptoms, but is transient, or a psychiatric disorder in 2 of the following domains: memory, reasoning in complex tasks. These are the executive functions you'll hear about: visual spatial, language, and personality. Notice memory is not required. In some of the dementias, memory is not as big a feature. And for the diagnosis of dementia, they have to be sufficient enough to affect daily life. So it's objective findings and functional impairment. Recently, there was an initiative on dementia nomenclature, because there are so many terms that are flying around, and they did a very nice job. Unfortunately, it didn't make things a whole lot easier, but it did separate into clinical features, which could be classified by domains, what is affected, by severity, how severe, age of onset, and the functional impact. But there's a whole nother way of classifying dementia, and that is due to pathologic features, whether this is Alzheimer's with amyloid and tau, whether it's due to Parkinson types of dementia, Lewy bodies, where you see alpha-synuclein, or vascular. And so what they came up with finally is there's a clinical syndrome and a pathophysiology. And on the end of that becomes a disease label. Now, there's I don't think it's an acrimonious war, but there's a small war that's going on worldwide here about Alzheimer's disease. And the Alzheimer's Association has really gone on the side of it being a pathologic biologic disease, whereas there's an international working group that is operating under a clinical biological construct, whereas there has to be clinical features, whereas the Alzheimer's Association definition is really strictly based on the biology of it. And this kind of difference in focus really is important, particularly in policy determinations, clinical care, and also in drug development. So I'm not going to go through each of these, but you can take a look at the slides later. All right, let's shift to what causes dementia. So this is an old slide from the Alzheimer's Association. They have allowed me to use it. And it's a great slide because people ask you all the time, Doc, what's the difference between Alzheimer's disease and dementia? And this caption captures it all, where it says dementia is the umbrella and Alzheimer's is just one cause of the dementia. And it's the largest. 60 to 80% of Alzheimer's dementia is caused by Alzheimer's disease, but there are others. Lewy body dementia, we just spoke about that, vascular dementia, frontal temporal degeneration, etc. Well, this slide is old, and we're learning a lot more. This is a very interesting study that was published a few years ago from the Religious Order Studies and the Russian Memory and Aging Project. And what you'll notice here is that the gray, we're seeing here, these are not cognitively impaired, mild cognitive impairment, and probable Alzheimer's dementia. The gray is actually a small slice. And what you're seeing here, mostly this is Alzheimer's and vascular, this is Alzheimer's and other diagnosis, this is Alzheimer's and other diagnosis and vascular. We're seeing more and more, and certainly more than half of people with dementia have more than one cause of it. So it's really a multifactorial disease. Stages of dementia. So they're classically categorized as mild, moderate, and severe. And the first things that people tend to see are social withdrawals and mood changes and apathy. Okay. Poor insight and judgment. This is when everybody seems to be doing pretty well, but they're not getting it. And decreases in short-term memory come first. And here you start seeing some consequences such as trouble managing finances. A patient of mine who had dementia was unrecognized for a number of years before I started caring for him, owned a radio station and bankrupted it, basically. Here you get in trouble with driving or not taking medicines correctly. And as it progresses, worsening memory, you see the repeating questions, functional impairment, some of the Katz ADLs, getting lost. And then you start seeing behavioral complications, delusions, agitation. And finally, difficulty with remote memory. One of the saddest things is when people can't even recognize their own family members. I saw a patient yesterday afternoon. The way I test his memory is I ask him to remember his son, his daughter, and his brother. And on a good day, he can do so. On a not so good day, not so much. Decreased verbal output, apathy, ADL impairment, sundowning, and then the medical complications, falling as a result of increased mobility and swallowing difficulties with aspiration. The natural history mini mental state examination, which has been used for many, many years, shows a pretty consistent 3 to 4 point drop on a 30-point scale every year. Probably more meaningful survival time from time of diagnosis. And here there was a recent review on this that showed that among men, if you're 65 years of age, you have about almost 6 years to survive. If you're 85, it's more like 2.25 years. If you're a woman, if you're 65, it's 8 years, and 4.5 if you're 85 or older. But perhaps even more important is how much time you have remaining out of a nursing home. And on average, it's 3.3 years. But interestingly enough, 13% are admitted in the first year after diagnosis, and more than half by 5 years. Okay, this is a slide that talks about from a policy perspective and from a clinical perspective what we have to offer. Now, 2025, more than 7.2 million have dementia. And detection, we're actually quite good now at detecting disease. Treatment, we have some treatments. I'll talk about them in a few moments, but they're not great. And then support of patients with dementia and their caregivers. And these can be provided either in the healthcare system or in the community. We'll talk more about that in a few minutes. However, 2030, not that far off, there will be 8.5 million people with dementia. And hopefully by that point, we'll be able to identify risk factors. We're getting better at that. We'll be able to monitor better. We'll be able to prevent. And there's some interesting things with the finger study and the pointer study and the SMART study that show that maybe things are preventable. We'll have good detection, better treatment, support, once again, in the healthcare system and in the community. Manage the disease. In 2011, around the same time the diagnosis of dementia was most recently established, for Alzheimer's disease, they categorized it into 3 stages. Preclinical, where you have normal cognition, and it's really identified by changes in biomarkers. The second is mild cognitive impairment, where there is impaired cognition, can be demonstrated on testing, formal testing, but functional status is intact. And positive biomarkers may help determine the progression to dementia. Finally, the third stage is dementia, where there's impaired cognition and function. And biomarkers may be helpful in actually excluding or including Alzheimer's as a cause. Now, this 3-stage model may sound familiar. And the reason why is it is familiar. It is the same thing we use for coronary heart disease. The preclinical is equivalent to a high cholesterol. The MCI stages when you see atheromatous plaque. And the dementia stage is equivalent to a heart attack or a stroke. And indeed, much of the research that is being conducted follows along the lines of these 3 stages. And indeed, in 2018, the ATN research framework was established, whereas the first signs are aggregated A-beta amyloid, and that can be detected through CSF, spinal fluid, or an amyloid PET. T is aggregated tau, which are the neurofibrillary tangles. And indeed, these are really the hallmark of Alzheimer's disease. And most categorization systems say if you have tau, you have Alzheimer's disease, including the Alzheimer's Association categorization. Here, this can be detected in a CSF or a tau PET scan, which is not commercially available, but it is being used in research. And then finally, the third stage is where there's actually neuronal injury. And that's not necessarily specific to Alzheimer's disease, but it can be detected on special views of a conventional MRI, which is called a volumetric analysis. A FDG, that's essentially a glucose analog PET scan, which is available and which Medicare will cover in certain circumstances, or CSF total tau. So this is how people are thinking about the Alzheimer's disease. And this is a terrific slide. There's about a half a dozen different papers saying pretty much the same thing and many different ways of portraying this. This happens to be CSF markers, but it could be shown with other kinds of markers. That this dotted line here is the time when Alzheimer's disease is diagnosed, when the patient and family are told this is what's going on. But if you go back in time, 17 and 18 years earlier, you can detect abnormal amyloid. And indeed, phosphorylated tau, which is that second stage, 11 years. And then beginning to have symptoms a few years beforehand. So this is a disease that takes a long time to come to clinical attention. A lot is happening earlier. And here is what I consider to be a big breakthrough. Commercially available blood-based biomarkers. Now, the last slide was very interesting and very helpful, but not everybody is going to want to have a spinal tap, lumbar puncture to determine whether they have these biomarkers. On the other hand, people are probably pretty willing to roll up their sleeve and get a blood test. And indeed, these are commercially available. The AD Detect, which is not the best test, is actually you can get over the counter, $3.99 plus another $13 for a reading fee, and anybody can do this. There are a number of other ones that require a physician's order. None of these are paid for, but I've heard from our neurologists that they'll oftentimes get a discount on these. And you notice these are some of the ones that we had mentioned earlier. And then in May of this year, the Lumipulse G, which is a p-tau 217 to beta amyloid 142 plasma ratio, was approved by the FDA. So we are going to start seeing this used much more commonly and probably get reimbursed. I've listed here a website that can give you every update on all these biomarkers because there's a lot of them. But this is where the puck is going. Okay, manage the disease. There are drugs available and have been around for a while. The cholinesterase inhibitors, they all have generics at this point, but there are some formulations of doses and combinations that are still proprietary. The drugs are donepezil, galantamine, rivastigmine. There's also a transdermal version that is proprietary still, but it tends to have fewer GI side effects. There's actually a transdermal donepezil out as well, but both of those are proprietary. These have been demonstrated to be helpful for Alzheimer's disease, dementia with Lewy bodies, vascular, if there's a mixed component, and Parkinson's disease dementia. These are basically neurotransmitters. They increase the amount of acetylcholine that goes from one neuron to another. They do not benefit frontal temporal degeneration, which has a different mechanism. And they don't, and this has been tested a number of times, prevent the progression of mild cognitive impairment to dementia. The second drug that's available is memantine, and that has inconsistent effects on cognition. Doesn't really affect function, small improvement on a clinician-rated impression of change. And it is indicated only for moderate to severe Alzheimer's disease. Its effect in mild to moderate disease are less certain. So those are the two drugs that are used mostly. And then the anti-amyloid. We've certainly heard a lot about this, beginning with aducanumab, which was approved in 2021, but is now no longer being marketed. It was a company decision to go with a different product. But the two that are available are lecanemab and donanemab. And they both have some supporting data, but not sufficient to meet usual FDA criteria. These drugs are very effective. They're monoclonal antibodies, very effective at removing amyloid. So if you think this whole disease process begins with amyloid, if you remove the amyloid, you'd expect that you'd have dramatic improvements for the patients. But in fact, the improvements are much more modest, like an additional 6 months of cognitive function preserved. They are aimed at people who have mild cognitive impairment or early Alzheimer's disease, people with moderate or severe Alzheimer's disease. They haven't really even been tested in those populations because they felt that they would not be effective. They require accurate diagnosis, including amyloid scans and very close monitoring with MRIs. They can cause brain edema or hemorrhages. And they're very expensive, about $28,000 per year for these drugs. So there are other compounds in the pipeline. There's actually a trial that's going to be completed this year of semaglutide, the diabetes agent that's also good for obesity. There's some hint that it might do something in terms of prevention. Stay tuned. Manage the patient caregiver. So a concept that has emerged is comprehensive dementia care that focuses on both the patient and the caregiver and includes continuous monitoring and assessment, ongoing care plans, psychosocial interventions aimed at both the persons with dementia and their caregivers, self-management, medication management, treatment of related conditions, and coordination of care. Second big principle of managing the patient and caregivers, this is the lifelong disease. There are no cures, and each patient has a unique journey. Play the ball where it lies. If the disease is early, include the patient. If late, you're going to need to rely on the family and the caregivers. And you want to work for the highest level of independence that works for everyone. If the situation is that a daughter needs to lose her job and spend 24 hours a day taking care of her mom, that may not be the best solution for everyone. She may burn out and everyone might lose. So you're looking to thread the needle to find the best course that works for everyone. Manage the hot button items like driving. I just got an issue with that yesterday. I was dealing with a patient who was furious at me. Living alone is another hot button item. Manage the other diseases, the comorbidity. Manage the symptoms and complications. Caregiver support. Caregivers are the most important resource that a person with dementia may have. I always tell my patients and their caregivers that it's not me, the doctor. It's not the dementia care specialist. The most important person is the caregivers. Yet up to 40% of them develop depression. The more knowledgeable and empowered the caregiver is, the better the care that the person with dementia will receive. And there are some excellent caregiver training programs, the REACH2 program, the NYU Caregiving Intervention. The Alzheimer's Association has numerous resources for caregivers that are effective. And I must interject here and call attention to best programs for caregiving, which was developed at BRI. It is a free online directory of proven programs for caregivers, and they look at the evidence. And there are 45 top dementia care programs that are around the country, and this is their website. But now there are two versions. One is for professionals who want to improve their care and gives them details and helps them compare programs. But there's also a public version now for caregivers and their helpers. This is pretty new, and they can search on zip code. And some of the things that are very nice, there's 28 organizations that offer programs nationwide and 176 organizations that offer local programs. So this is a terrific resource. There are some limitations to caregiver support. They tend to focus only on the caregiver, whereas comprehensive dementia care focuses on both. Much of the research conducted on caregiver interventions have been really traditional research designs rather than in real world pragmatic designs. They are not cheap necessarily. A couple of years ago, I pulled the data on this, $250 to $5 a day for 6 months. And perhaps one of the biggest issues, and I think this remains a challenge for us, is these function oftentimes at community-based organizations, and they aren't very well integrated with healthcare systems. Manage complications. So these are just for Alzheimer's disease, but there are similar data for other causes of dementia. These are symptoms that occur any point during their disease. And you see that apathy and anxiety lead the list. Okay. The worst fears, these hallucinations and delusions are relatively uncommon. They occur, but relatively uncommon. But apathy, anxiety, irritability are things that people are likely to have to deal with. So managing these. Without drugs, they're using behavioral approaches such as the DICE approach, which is very valuable. There's good evidence for formal caregiver training. There's a lot of others that research is being conducted on, including music therapy, cognitive stimulation, reminiscent therapy, animal-assisted therapy, creative expression. They all have some evidence, but are really still being studied. A couple of years ago, we created some videos for our dementia care program. These are publicly available. They're short. They're 2.5 minutes per complication, and some of them had millions of hits. So feel free to go there. Okay, medications. This is kind of the anathema. This is every dementia care provider's nightmare. SSRIs, particularly the best studied, has been citalopram. They improve agitation, but they may actually hasten cognitive decline. So, benefit you get, you also take a hit. The atypical antipsychotics are not very effective, but some patients benefit. They have the potential for a lot of side effects, including falls, further cognitive deterioration, and higher mortality. 4.5% versus 2%, generally due to cardiovascular or infectious causes. And you have to make patients, or at this point in their disease, their caregivers aware of these. You have to tell them that this is a risk. But most of the time, in my experience, when these medicines are being contemplated, the patients are so disruptive that the family will grasp at anything that might be potentially benefit. A couple of others, pimavanserin. This is a medicine that's used a lot in Parkinson's disease with people who have hallucinations, and it's been tested in patients with Alzheimer's disease, seems to have some benefit, but is not FDA approved. Dextromethorphan, quinidine, there's one clinical trial that showed some modest benefit. There are a lot of mood stabilizing medicines, valproic acid, carbamazepine, lithium, but really there's not much data to support these. So switching to new models of comprehensive dementia care. These focus on both the patient and caregiver, and there are 7 of these that really have some good evidence-based for them. They differ. They differ in terms of what kind of provider is the dementia care navigator. Sometimes they're particularly community-based organizations, social workers, or bachelor's level nurses, all the way up to advanced practice providers. And so the setting in which they're delivered, the type of provider differ. And this is not to be looked at in great detail here, but I've created a chart that compares the 7 different models and how they differ in structure, personnel, the site at which they're delivered, whether they have face-to-face, order rating capabilities, and the benefits is based in studies, observational and clinical trials. So take a look at this at your leisure. So which is better? Which is best? The answer is we don't know, and hence the DCARE study. For those of you who know much about PCORI, they're really very interested in comparative effectiveness. So in 2017, we proposed a study called the DCARE study, and that was to compare the effectiveness of two established models. One of community-based dementia care, the second is health system dementia care, and compare both to usual care. It's a pragmatic randomized clinical trial at 4 clinical trial sites around the country, 18 months of intervention. The plan was to have 1,000 in each of the intervention arms, and because the effect size was expected to be greater, fewer in the usual care. They had to have a diagnosis of dementia and live in the community, including assisted living. They had to have a friend or a family caregiver who spoke English or Spanish and have a phone. They were randomized on a 7:1 ratio. There we go. Okay. So the health system based dementia care was based on the UCLA Alzheimer's and Dementia Care Program. It's dementia care provided by an advanced practice provider, usually a nurse practitioner, but sometimes a physician's assistant, who is based in the healthcare system and can write orders and has accessible 24/7. Most of the originally was face-to-face interventions, but also telemedicine. The community-based dementia care arm was based on the BRI care consultation model. And there it was delivered by a social worker, care consultant, or a nurse at a community-based organization who provided coaching on doctor visits and educational resources. And these were all done by telephone. And usual care was what people got. They also were given the Alzheimer's Association hotline. These are the outcomes, and we won't go through all of them right now, but the primary and secondary ones we'll mention. The NPI-Q is a symptom severity score for the person living with dementia. The Modified Caregiver Strain Index is a caregiver instrument that assesses basically how disruptive dementia care has been. The NPI distress symptoms is the symptoms that the caregiver is experiencing on the basis of the person with dementia's behavioral symptoms. Caregiving depression, that's a very common instrument. And then caregiver self-efficacy, how well they report being able to cope with the stresses of caregiving, how informed they are, how empowered they are. And there's a number of functional status, quality of life, goal attainment scaling, and healthcare utilization measures that many of which are still pending. We also collected physician feedback about how they liked the different interventions, fidelity, and we're collecting quality measures. COVID occurred during the trial, and we administered a COVID-19 impact questionnaire about how much the disease impacted caregiving, and then quality indicators. So this is the story of DCARE, and this shows you our recruitment. And then you hear this is by month, and oh my goodness, what happened here? Well, on March 16th, 2020, all clinical trial research in the country was stopped, basically. And that was because of COVID. We were very fortunate. We got back into the field with some modifications of the protocol within about 6 weeks and finished up recruitment in January 2022. These are our targets, and we actually over-recruited a little bit. So all of their sites reached their targets. And this is what people look like. This is a complicated slide, but I'll go through just a few things. These people were old, average about 81 years. They're mostly women, which you see in almost all clinical trials. They were reasonably ethnically diverse. About 20% were ethnic minorities, either African American or Latino, Hispanic. And they were quite cognitively impaired. This is a version of the MoCA that we conducted, and had a lot of functional impairment at the more IADL level rather than the Katz level. Most of them lived at home. Only about 5% lived in an assisted living facility. And their caregivers actually were a bit younger because that's a diverse population. Some were spouses. In D-Care, almost half were spouses, and the other half were children. Once again, the ethnic distribution very much mirrored the with the person with dementia distribution. And these people were moderately stressed going into this. So these are the results. These were published in JAMA in January of this year. And what you want to, the important thing here is this dotted line. So the dotted line is no difference, no changes. Okay. And what you see, you're looking at the whisker bars here on the side, is that you don't want the whisker bars to include the dotted line. And what we see here for both of the primary outcomes and two of the secondary outcome, they cross the dotted line. Hence that there was no demonstrated benefit of treatment comparing arms. That includes the health system versus community-based, and both of those compared to usual care. However, in both the health system-based and the community-based dementia care compared to usual care, caregiver self-efficacy was statistically better. So we have done some additional analysis, and this is the scorecard of our outcomes. Anything that is in gray, we have not shown benefit on. But caregiver self-efficacy, caregiver rating of dementia quality, the community-based dementia care arm compared to usual care was better. And both of the intervention arms, were better satisfaction compared to usual care. Well, interpreting the D-Care findings, this study is at odds with some of the observational and clinical trials of similar interventions. Why? Well, this was very highly pragmatic, using clinical and community staff in real-world settings. So did this affect intervention fidelity? We're looking at that. Usual care may have provided access to more resources than other clinical trials. There weren't a high percentages of people who contacted the Alzheimer's Association helplines, fewer than 10%, but they may have gotten other kinds of resources. But perhaps the more important and related is that clinical trial sites may have implemented other quality efforts to lead to better care in usual care. Many of these other studies were conducted a long time ago. The choice of primary outcomes may not have captured the benefit. We did a similar study a few years ago where we took a look, we asked all the people who didn't demonstrate any benefit on any instrument and said, you know, the intervention didn't seem to help you. And they said, what do you mean it didn't help me? It was great. So the choice of outcomes may not have been optimal. But perhaps the most important was the vast majority of the study was conducted during COVID, which may have had independent effects and also impeded the delivery of both the health system dementia care and community-based dementia care. The resources just weren't available. Next step, we are looking at goal attainment scaling. That analysis should be done this summer. We have abstracting the medical records for fidelity of the health system dementia care arm, and the BRI database is going to help us with quality indicators for the community-based dementia care. We will be looking at utilization for 18 months. And we're going to look at costs of the care, net intervention costs minus any cost set from reduced medical care and caregiving. Okay, fast forward a little bit. July 31st, 2023. It was a Monday morning. The Center for Medicare and Medicaid Services held a press conference attended by the Secretary of Health and Human Services, at which they announced the new voluntary nationwide 8-year model guiding an improved dementia care experience. I remember this very well. I was watching it from home. It was 7 o'clock in the morning. They were having terrible technical problems getting the distribution of this on Zoom. But when they started to speak, I wept. I wept not only, I didn't weep for anything that we had done at UCLA. I wept for all the people around the country who were going to start getting better care. So the goals of GUIDE are to improve the quality of life for people living with dementia, reduce the burden and strain on unpaid caregivers of people living with dementia, and prevent or delay long-term nursing home care. So this is what DCARE is supposed to do, what GUIDE is supposed to do. And they're very prescriptive about it. Standardized approach to dementia care delivery. I'll talk a little bit about that in a moment. However, they are providing an alternative payment methodology. So people enrolled in the GUIDE program will get a monthly per beneficiary payment to support this kind of care. This is in addition to fee-for-service billing. Okay. This is new. Addressing unpaid caregiver needs by providing caregiver training, 24/7 support, respite services. These are temporary services provided in the person's home, adult daycare center, or a facility that can provide 24-hour care. This is the first time that Medicare has ever done anything for caregivers. And then screening for health-related social needs and helping navigate caregivers and persons with dementia to community-based organization to address these. Here, Medicare really got it right. So the participants are Medicare Part B enrolled providers. They have to have a care navigator who's received training, but they do not specify who the care navigator needs to be, what kind of credentials. However, there also has to be a clinician with dementia proficiency involved. That can be a neurologist, psychiatrist, geriatrician, geriatric psychiatry, etc. There are 2 tracks. The established program, these were programs that were already providing comprehensive dementia care, and they started enrolling patients and billing in July 2024. And the new program track that got a year of ramp up without any funding, but to get things running. And they will begin to start seeing patients and get paid for these patients in July, 2 weeks away. Who is eligible? Patients have to have a diagnosis of a dementia. This is not a mild cognitive impairment intervention. Medicare has to be the primary payer. And this is important, they have to be enrolled in Medicare Part A and B, but not Medicare Advantage. And as you know, Medicare Advantage is really even more common now than traditional fee-for-service Medicare, more than 50%. Also, special needs plans and PACE are excluded. So it is a minority of people that would even be eligible. can't be enrolled in hospice or live in a nursing home. The standardized delivery approach, 9 domains, the interdisciplinary team, the navigators have to be trained. You have to create a patient-centered plan, care coordination, and caregiver services. And they are precisely defined here. Payment. As I mentioned, it's a per beneficiary per month. The amount is based on 5 categories. First of all, whether a patient has a caregiver or not. It's more if the patient has no caregiver. And then the severity of the dementia or the complexity, whether it's mild, moderate, or severe. Basically, that is severe is high complexity. There are payment adjustments based on geography. And these are national standards in terms of payment adjustments, health equity, and performance. But the great thing is that each person who's enrolled has payment allocated up to a cap of $2,500 per year for respite services. This is somebody coming in the home to provide respite services for 4-hour blocks, adult daycare in 8-hour blocks, or overnight at a facility. So to wrap up, I'd like to just conclude by saying dementia is common and will increase as the baby boomers age. We've got a lot coming up. Current pharmacologic treatment is limited. Who is eligible and how effective they are. Currently, estimates of only about 15% of people would be even eligible for anti-amyloid treatments. And the other medicines are modestly, at best, effective. But there's hope. There are a lot of drugs that are in trials now, and hopefully some of them will pan out. All persons with dementia and their caregivers need comprehensive dementia care. It is a journey. At different stages of the disease, the needs will change. There are several evidence-based models that are available for adoption and adaptation. Thus far, the evidence seems to suggest that they have comparable effectiveness. And I'll confess, I'm pretty familiar with all these models, and each one has desirable components. A lot of it depends upon the fit for the healthcare system and for the patients, what's going to be best for them. They're all great. And guides should facilitate better dementia care. Currently, they estimate that about 200,000 people will receive guide care over the next 8 years. And for these people, they will be determined whether this may eventually become a benefit for all persons with Medicare. So stay tuned, and I'm glad to answer questions. And the slides will become available. Take a look at some of the areas that I couldn't spend too much time on.
Thank you so much, Dr. Reuben, for that comprehensive, informative, and insightful presentation. And I see that Q&A and chat are asking a lot of really good questions. So we're going to go ahead and move forward to the question and discussion section of the lecture. So I would now like to introduce Dr. David Bass, Senior Vice President of the Benjamin Rose Institute on Aging. Dr. Bass will begin the question and discussion segment of the presentation. Dr. Bass leads the research and education arms of Benjamin Rose and is a friend and collaborator with Dr. Reuben on several initiatives, including the Dementia-Care Study and the National Dementia-Care Collaborative. Dr. Bass's current research focuses on evidence-based programs for people dealing with Alzheimer's, including best programs for caregiving and BRI care consultation. During the question and discussion segment, please continue to post questions in the chat and Q&A, and we will address questions from audience as time permits. Thank you so much. And Dr. Bass, I'll pass it over to you.
Thank you, Megan. Thank you, Dr. Reuben. I think Dr. Katz would admire and approve of your presentation. And the reason I say that is because you covered an amazing amount of territory. You looked at people living with dementia and their caregivers in a holistic sort of way. in the context of their families. And that holistic perspective is something that Dr. Katz brought to every discussion that we ever had with him over the years. And your presentation was right in the spirit of that. So thank you so much. We really appreciate it. Now, I'm decided to take the liberty of asking a few questions to start the question and answer period off. So while I'm doing that, please add your questions and we'll get to audience questions as well. But I'm going to start with an icebreaker question to give Dr. Reuben a chance to catch his breath. And so Dr. Reuben has lots of interests beside geriatrics and dementia care. So I'm going to ask a question on one of those interests, which is baseball. And so I'm going to give him a baseball question, and you're going to have to explain a little bit in your answer, because my question to you is, for generations who are 40 or younger, will Shohei Ohtani become the substitute for Babe Ruth as the most legendary baseball player? This is down the road. And Dr. Reuben's also a Dodgers fan, so that helps to put the context of this question. So what do you think about that, Dr. Reuben?
I hope so. I hope so. I think Shohei Ohtani is good for baseball. And you know what? I think he's good for international relations and respecting people. Just as Jackie Robinson made a major contribution to helping with breaking down the color line, I think Shohei has got the potential to really do a lot more in terms of realizing we're one world. Megan mentioned that Dr. Bass and I were close friends, and we actually share the same first name. But if it comes to the Dodgers and the Guardians in the World Series, it may not be pretty.
Probably not going to come to that. So I don't think we need to worry about that. All right, I'm going to jump into a few questions that I wanted to hear your answer to that relate to your presentation. So the first one is, your presentation and your interest in quality dementia care came through. And I'd like your perspective. What future research do you think is needed to better understand the features and components of quality dementia care?
Thanks. That's a great question, and actually it's very dear to my heart, because I've done a lot of work in my career on quality. And quality is kind of like the sirens on the rocks. So because we think that if we measure quality and we improve quality, it will lead to better outcomes. That's the whole principle behind quality indicators. And it turns out that sometimes that's the case and sometimes it's not. There have been a number of studies in cardiology where they get with the guidelines and things like that, where they've actually shown improvements in quality, but those haven't translated into the same kind of clinical benefits. So that remains a question for further study. I have a hypothesis. I have a hypothesis that in fact all of the evidence-based dementia care models can improve quality, and I think it's much more important to improve quality than it is which model does it. And that's a testable hypothesis. That's one of the things we're going to look at in DCare. But there are many ways to skin a cat, as they say, it really matters which works best. But then there's all that lingering question: is whether if you improve quality, does that improve clinical outcomes? So a lot of research ahead.
Thank you. All right, next question. Do you think the increasing number of persons living with dementia and techniques for early detection will change the stigma of dementia in our society?
Stigma is a hard thing to change. It definitely is. Our president of the United States, Ronald Reagan, was had dementia, and he was out about it. Um, I would like to say it changed the stigma for him, but it didn't. Interestingly enough, and I happen to know a lot about Ronald Reagan. But was not his doctor, but I do know a lot about Ronald Reagan, and his doctors at the time kind of talked to his family in front of him without including him in the conversation. And I still think that there are just such obstacles to it. Um, it's not just like any chronic disease. Sometimes these people are yelling and screaming and agitated, and that's hard. It's hard for people who are healthy, to whether they be people at a daycare center, or whether they're people in a grocery store, whether they're healthcare providers. When somebody's yelling at you or trying to bite you, it's hard to deal with that. So I think it's a very challenging thing to overcome that kind of stigma. But they are people. They are people, and they're people who have been loved. And it's our responsibility at every opportunity to proselytize that these are people, and they are people who loved us. One of my patients who I was just in communication with yesterday, her daughter has given up everything to be with her mom. But I heard from one of her previous physicians that this is payback because her mom got her through all this difficulty during her childhood and adolescence. So it is a covenant between generations and between people who are well in society and people who have this devastating group of disorders.
Thank you for such a thoughtful answer. Appreciate that. All right, next question. Do you think there needs to be changes in federal or state policies to increase the availability and use of caregiver support services? If so, what policy changes do you think should be considered? So that's the availability and use of caregiver support services, and whether there's some policy changes needed to increase their use and availability.
Yeah, I think absolutely. Absolutely that, as we mentioned, these people are expensive. They're about $45,000 a year. And for each person who's affected with dementia, how that $45,000 a year is spent, there will be an optimal way of doing that. So for one person, it may be, having 24-hour caregivers that are family members, and then using other services to fill in and give respite care. For another, it might be what we call here in California board and care, which are small group homes or greenhouses or something like that. But there was a program that used to have in California called Money Follows the Person. So if you're expecting to spend this kind of money, what is the best way? And I would bet that a lot of it is focusing more on caregivers, having them better trained, have higher self-efficacy, having respite, making sure they're in good health. I think, and how that money is actually funneled into the caregivers is still a question. And maybe Guide will help us with that, seeing how well the services are utilized, which services are utilized, and when they're running out. If the services are for a year, and if people are using them all in the first month, that tells you there's a deep need there.
Thank you. What about the relationship between healthcare services and community-based services? What kind of changes do you see needed to bring a closer partnership between those two sectors?
Oh, that's music to my ears. I've been saying this for a long time. Yeah, I think there's actually a kind of a window of opportunity. And I think one of the windows is the guide program, because many of the services healthcare systems can't provide, or if they did provide it, it'd be much more expensive. And basically, it capitalizes on the best that each of the sectors, healthcare and community-based, their strengths. And so Guide has required a lot of participants to establish new relationships with community-based organizations. And that's fantastic. And then the community-based organizations are paid, which is good. That's been a rate-limiting step, is that money has not been able to flow into community-based organization on a per person basis. The other hope of optimism here is electronic health records. And electronic health records now are able to connect to outside organization. I mean, there's some firewalls and there's some HIPAA types of issues, et cetera, but there are ways of communicating and even having community-based organizations documenting in the electronic health records. So this is a technological solution that I think 10 years ago we just wouldn't have had, but it is a great opportunity to bring community-based organizations and healthcare organizations together, and it's desperately needed. It's all the prescriptions you can write in the healthcare systems, they're not going to fix dementia, whereas many of the social services that are provided in community-based organizations can be a big part of the solution.
Thank you. All of us that work in community-based organizations have valued your perspective on this before today, and we appreciate your answer. I'll ask one last question, then I'll pass it to the audience. Based on your observations of the early phase of the guide implementation, what is your current assessment of its strengths and limitations? And you've talked a lot about guide in your presentation and highlighted some of its positive features, but wouldn't hurt for people to hear those again. But also, what are the limitations that you see in guide at the moment?
Yeah, so Guide is like, being the pioneers going out to the Wild West. This is new. This is incredibly new. We heard that we were a guide site on, I think, April 2nd, 2024. And on April 7th, we created a task list of things we needed to do. And we're a program that's been operating for 10 years. So we kind of knew what we were doing. 32 items on the list. Okay. And, here it is almost a year and a quarter later, and we still have about 30 items on the list, but they're different items. So, all sorts, there's tremendous amount of organizational changes that need to be done, both to implement Guide from a clinical perspective, but also from a regulatory perspective. There are just all sorts of some submission requirements and documentation requirements, and CMS is changing the rules a little bit here and there. So it's a bit cumbersome. So that that comes with the territory. If you're going to be a pioneer, if you're going to be an early adopter, you need to accept that. On the other hand, some of our patients have just loved this. Getting a respite care, getting a care navigator, they're like royalty. So I think it's unexpected. This is kind of what we expected. Some of the sites are having some difficulty with recruitment, but I think that hopefully is transient. I think that. I think I'm optimistic, but it takes a lot of work. And the one thing that the healthcare systems need to, or guide participants need to hang in there, because anything that you start is going to have some bumps along the way. So ride them out. The first year may not look great, but this is an 8-year project.
Yeah, thank you. That's so important that we all keep the newness of this in mind and the learning that's got to go on in these first few years. And I just want to, I'm not going to ask any more questions. I'm going to pass to Megan to bring up questions from the audience. But before I do, I just want to acknowledge how important your work has been to make GUIDE happen. So much of what you've done in the past has helped to shape GUIDE. And so all of us who are enthusiastic about having GUIDE as a part of Medicare and a chance to actually support caregivers the way that hasn't happened in the past, we all owe you appreciation. So thank you very much. I'm going to pass it to Megan, and you'll get some more questions for the audience, but thank you, Dr. Reuben.
Well, I was just a very small cog in a large machine that was turning. They were ready for this.
Thank you both so much. We have so many questions from the audience, so I'm going to do my best to pick and choose here. Would you be okay with answering some of these questions offline as well?
Sure. Just forward them to me.
Wonderful. Okay. So I'll start off with, are there important advantages to early screening for diagnosis, or should it be contingent on emergence of meaningful symptoms? Does diagnosis too early have negative impacts?
So they actually studied this, that early diagnosis did not have a negative impact. There was an NIH study on this. There are some advantages to early diagnosis, particularly with advanced planning. And that doesn't necessarily mean end-of-life planning, but it has to do with how you want to spend your years and what you want to be doing and what's important to you. It's very important. There are some people who may not want to know. They may not want to know. And for them, there may be an advantage of not knowing earlier. So one of the questions, and you'll see this is going to rise over the next couple of years, is whether to just like you're an older adult and you go to your doctor's office and they get a cholesterol. Should you be getting a 217 tau test? And thus far, there have not been recommendations for that. And for me, that would be a personal decision. For me, I would not want to know. We will see this, right now these tests are being done mostly for confirmatory. I think what we're going to see in the next year or so is that the CSF biomarkers are going to kind of fade away because they're not going to be as desirable as the plasma biomarkers. But they're currently recommended only more or less for confirmatory and in memory clinics.
I guess writing off of that, there was another question. Is there an age limit on biomarker testing?
Is there an age limit? Since only one of them is approved, and I didn't see an age limit on the approval, no, all the other ones are not approved. They're not approved by the FDA. Anybody can get them.
How do you think palliative care models can improve dementia care, including primary and specialty palliative care across the disease trajectory?
Yeah, there was just a study called the INPEACE study that integrated a palliative care component, a strong palliative care program with comprehensive dementia care. It did not have major effects on caregiver strain and behavioral symptoms, but it did reduce utilization, and particularly among some minority populations. And that was very, very positive. Palliative care is part of dementia care. It's just a component, and when it starts, it really depends upon each individual patient. But you can't provide good comprehensive dementia care without integrating palliative care.
How do you make sense of improvements in self-efficacy but not caregiver depression, since often the literature shows higher self-efficacy is associated with lower depressive symptoms?
Yeah, that's something I've lost a lot of sleep over. The it's interesting. These appear to be different constructs. They're somewhat related. You take a look at the correlations of these different instruments, and they're not all that high. So, think of your own life. You may be sad. You may be depressed. You may have symptoms, but you shoulder on. And I think that caregiver self-efficacy is kind of that shouldering on and getting through things and saying, geez, this is a bad situation, but I'm going to get through it.
The question of what measures does GUIDE use to determine severity of dementia?
Yeah. So there are two measures that are currently required. That one is caregiver rating, a rating scale of severity of dementia, and that can either be the FAST or the clinical dementia rating scale, sum of boxes. They're both fairly comparable. FAST is a little quicker. But the second part of the question that wasn't exactly asked is for tiering, the difference between a moderate dementia and a moderate complexity and high complexity is based on the caregiver's symptoms. And there they're using the Zarit Burden Inventory, although alternatives can be used. But it's really relying on the Zarit score.
Do you worry or have concerns of the MOCA being overused by persons who are not well trained on how to administer and score it with the GUIDE program? I ask because as a psychometrist, I often see inaccurate MOCAs that were done in PCP offices, social works, etc.
Yeah, MOCA is an interesting instrument. It's interesting in how it's administered. It was also designed to detect mild cognitive impairment. So, for example, compared to the mini mental state examination, it's a harder test. It takes longer, et cetera. So one of the things, MOCA is really designed as a screening test. It's not a diagnostic test. A diagnosis of dementia really requires a clinical evaluation. So I think one of the concerns about MOCA and other tests that are for dementia that are, questions, a few questions here and there, is that they're in part being used for the wrong purposes. They're being used as diagnostic tests or for monitoring people. And they may be somewhat helpful for monitoring, but they don't establish the diagnosis. So I share some of those concerns.
You mentioned that recruitment was a barrier in GUIDE. Is that recruitment for other community agencies to offer respite?
Well, it's interesting. The recruitment I was referring to is the numbers of beneficiaries. So the story is that the CMS is hoping that each GUIDE participant has 200 enrollees after the second year. So we're just beginning to enter the second year, so people have some time. But the number of enrollees has been a little behind. Recruitment of participating community-based partners has been very sporadic. It's interesting. One of the things that we experience trouble with, and we're not the only one, is that the rates that Medicare sets for respite services, in-home caregivers, adult daycare, have been below market rates in those communities. And so that we have heard of organizations having trouble recruiting community-based partners because they weren't paying enough.
Scrolling up to the top of the chat here, early on in the presentation, we had a question labeled or critical. What do you think of SCI or subtle cognitive impairment is Alzheimer's disease?
I think maybe subjective cognitive impairment.
Oh,
all right. So yeah, this is kind of the ultimate slippery slope. That subjective cognitive impairment People who have that actually turn out to develop dementia at a higher rate. So it may be a very early warning of this. On the other hand, there are a lot more people out there who have subjective cognitive impairment or mild cognitive impairment, who it's either part of normal aging or it's not getting in the way. So I would, this is the Dave challenge. The Dave challenge is you fly across the country for us in California, or you guys can fly to England, and they put you on for to give a talk at 8 o'clock in the morning. And I can pretty much guarantee you, if you're above the age of 50 years old, you're going to have word finding difficulties. And that's part of normal aging. You know, these words that are on the tip of your tongues, people's names, et cetera, that give me 5 minutes and I'll tell you the right answer. And that's part of normal. I have that. I certainly have that. But they come back to you. And what I tell some of the patients, if they don't come back to you, then that's more a concern. But when they come back to you in a few minutes, just realize that you're earning your stripes of aging.
That makes me feel better too. Okay, how might workforce issues in healthcare and others, social workers, community health workers, especially those with interest in geriatrics or gerontology, impact the sustainability and scalability of programs like GUIDE? So
what was the first couple words? I missed those.
How might workforce issues in healthcare and others?
Oh, yeah. It's a big deal. Workforce issues, there is a workforce shortage in dementia care from top to bottom. Top being the clinical specialists, dementia care, physician specialists, nurse practitioner, and APP specialists. Too few. Many institutions, including ours, you're trying to get a neurology consult, it may take you 6 months. All the way down to the bottom. So the bottom is, the people who are non-certified or non-licensed caregivers, and many of whom are immigrants to the United States, just face it, and now are having issues with immigration issues, and who knows, may get deported. So workforce, we are woefully understaffed with our workforce to meet the challenge of all these new persons who are diagnosed with dementia. And indeed, one of the concerns is that some of the efforts, such as the HRSA Geriatric Workforce Enhancement Project, the GWEP, are being eliminated, or actually proposed to be eliminated. So we have a great concern about the future workforce and current workforce, which is inadequate.
Mm-hmm. Yeah. I think we have time for one more question. We'll end it on this. What do you view as the most important federal policy change we could make to better support family caregivers supporting those with dementia?
Mm-hmm. Okay, I'm going to take a kind of a cheap answer here, because I would say that the GUIDE program is the kind of direction we should be moving in. But over half of Medicare beneficiaries don't get GUIDE because they're not eligible, because they're in Medicare Advantage. If we could do something for the Medicare Advantage patients who have dementia that is similar to GUIDE, that would be a lot.
Okay. Well, I want to thank, did you have one more thing to say?
I was going to just say thank you.
Thank you. So thank you so much for being a part of our 19th annual Katz Policy Lecture, and for all of your engaging questions in the audience. Special thanks to Dr. Reuben and Dr. Bass for their presentation and sharing their expertise. So as we strive to enhance our future programs, we kindly ask you to provide feedback through a brief evaluation survey. Your participation is voluntary, and all responses will be kept anonymous. And you can access the survey by clicking the link provided in the chat and it will also be sent to you via email after today's lecture. We extend a warm invitation to explore our upcoming free events displayed on the screen. For further details and registration, as well as to learn more about Benjamin Rose research programs and services, please visit our website at www.benrose.org. So thank you again for joining us, and we hope to see you next year. Thank you so much.